Hello, this is Leanne Groban from Wake Forest School of Medicine. On behalf of my collaborators, I'm going to share with you the results from our single-center cohort study, Self-Reported Mobility in Older Patients Predicts Early Postoperative Outcomes After Elective Non-Cardiac Surgery. I have no potential or actual conflicts of interest to declare. This work was funded by the Anesthesia Patient Safety Foundation and in part by the Translational Science Center of Wake Forest University and the Integrative Medicine and Claude D. Pepper Older Americans Independent Centers of Wake Forest School of Medicine in Winston-Salem, North Carolina. Just a little background. As you all know, the population is aging and the number of older adults undergoing surgery is expected to increase. Indeed, older adults are at higher risk for postoperative complications than younger adults. Preoperative assessment of participant characteristics that can assist in the evaluation of risk for adverse postoperative outcomes is important to patients, their families, and their surgeons. Traditional risk assessments may be too comprehensive and too focused on single organ systems. Older patients often exhibit declining reserves in physiologic and physical function in multiple systems that might be overlooked by traditional preoperative risk assessment measures such as the American Society of Anesthesiologists Physical Status Classification and the Revised Cardiac Risk Index. While geriatric-focused risk assessments aim at multiple organ systems, they may be impractical or difficult to implement in a busy preoperative practice. Moreover, performance-based tests may be affected by transient states such as pain and acute illness. For example, this might occur particularly when attempting to evaluate physical function in older adults with orthopedic conditions. Therefore, the aim of this study was to test whether a simple, self-reported mobility assessment could predict postoperative outcomes in older patients after elective non-cardiac surgery. So we looked at 197 elective general surgery patients. They were 69 years or older. These patients were consented in the waiting room of our preoperative anesthesia clinic. Patients excluded included those for ambulatory surgery without a hospital stay, patients with hearing and vision deficits, and those who required assistive aids to walk. As far as the preoperative assessments, besides a routine medical workup, we looked at traditional risk score measures, including age, sex, body mass index, pain score, revised cardiac risk index, ASA physical status, and surgical risk. And we also looked at high sensitivity C-reactive protein as a measure of inflammation. We looked at a 5-point frailty score as described by Fried and later adopted by Macri for the preoperative setting. And then we did a self-reported mobility test using the Mobility Assessment Tool short form, or the MAT-SF. Now for the 5 criteria for frailty, this included unintentional weight loss of more than 10 pounds in the previous year, weakness as measured by a handheld dynamometer, exhaustion as measured by response to questions about motivation and effort, reduced physical activity as described in a leisure time and activity survey, and slow walk speed. Frailty was defined as the presence of 4 or more of the 5 criteria. Intermediate frailty was defined as the presence of 2 or 3 of the 5 criteria, and patients with 0 or 1 were defined as non-frail. The primary outcomes of interest were 1 or more postoperative complications within 30 days of the operation, and this was defined by the American College of Surgeons NSQIP, plus delirium and atrial fibrillation were added to the complication list. Time to discharge in days, and nursing home placement. Just briefly, the Mobility Assessment Tool short form, or MAT-SF, is a quick, reliable cost-effective clinical tool for identifying older adults at risk for future major mobility and disability. The MAT-SF presents 10 computer-generated animations that you see on the right that depict mobility tasks in different environments. This was implemented via an iPad. The MAT has been validated against measures of physical function, including the Pepper Assessment Tool for Disability, the Short Physical Performance Battery, and the 400-meter test among older community dwellers. If we look for the scoring on the MAT, it ranges from a very low score of 30.21 or poor mobility to a high score of 69.76, representing excellent mobility in older adults. Here is just an example of a real-world task, such as walking on an uneven path, and participants are asked, for how many minutes could you walk through rocky, inclined terrain at the faster pace shown without stopping? So in contrast to objective tests such as the timed up and go and the 5-meter walk test, there is no need for dedicated space, and concerns surrounding patient safety are eliminated with the self-reported mobility assessment tool. If we look at our results, look at the patient characteristics, our sample had a mean age of 75 years. 51% were women. With regard to traditional risk measures, 87% fell within a revised cardiac index class of 1 or 2. 69% of our patients were deemed to have an ASE physical status of 3. 72% of our patients underwent intermediate or high-risk surgery. More than 60% of our patients had an elevated C-reactive protein defined as equal to or greater than 1 milligram per deciliter. The median MAT score was 53 with the interquartile range of 46 to 61. 34% of our patients were intermediately frail, and we had one patient that was frail, making that percentage at 34.5%. 15% of our patients had postoperative complications. The median time to discharge was 3 days with the interquartile range 1 to 4 days. And 13% of our patients required nursing home placement. After controlling for traditional covariates, again that included age, sex, body mass index, pain score, revised cardiac risk index, ASA status, surgical risk, and CRP, we found that worse self-reported mobility associated with more postoperative complications, later time to discharge, and increased nursing home placement. By using the same model, intermediate frailty or frailty associated with only an increased risk for nursing home placement, but was not related to either postoperative complications or time to discharge. To assess the ability of the models to predict postoperative complications and nursing home placement, we perform receiver operating curve analyses. On the left panel shows the ROC curves for postoperative complications in models including the traditional covariates plus CRP and with either frailty or the MAT-SF scores. And the areas under the curve are 0.722 with frailty and 0.7623 with the MAT. On the right, you could see the receiver-operated curves for the models predicting nursing home placement based on intermediate frailty or frailty and the MAT. The corresponding areas under the curve were 0.8246 for frailty and 0.8441 for mobility. So even though the ROC curves show that the MAT-SF does similar to frailty in predicting postoperative complications in nursing home placement, we consider the MAT-SF to be more practical to perform and thus more appealing to be used in a busy preoperative clinic setting than frailty assessments. In conclusion, the MAT-SF is a quick, reliable, cost-efficient, and practical clinical tool for identifying older adults at risk for early postoperative adverse events. Low preoperative MAT-FS scores could be used to alert patients, their families, caregivers, and physicians of the potential for needing postoperative activities of daily living assistance, falls prevention, home modifications, or home health care after elective surgery. Studies in progress will test whether preoperative strength and balance training might limit adverse postoperative outcomes and reduce length of stay in older patients with self-reported limitations in mobility. Thank you.